correction, maybe it doesn't matter, but I left the department of Professor Szepetowski 4 years ago, so I decided to, I would say, become independent. So and as you can see that now I am from the Department of Dermatology in Rzeszów. It's still in Poland, but it's located in the east part, southeast part of Poland. And at the end I will show you some photos, because I would like to kindly invite you to come to this city as well, because Wrocław is beautiful, but Rzeszów is also not bad. And here I am at the head of the department of dermatology, but still I have some interest in some studies on patients with psychodermatology. So this is my conflict of interest, and I would like just to only underline that there was no influence of any company of this content. On the other hand, I am cooperating with so many companies that it's really hard to say that there is nothing not related. So I would like just to underline that this is those companies did not have any influence on this today presentation. So this is a little background for for my experience in delusional parasitosis. Definitely, it's not a very common disease, but we really have a kind of an interest in this disease. So you see some papers from our department and from me and from my colleagues, and also Professor Szepetowski, because he was my previous boss. And we also prepare a Polish book on psychodermatology, and it is the first textbook in Polish regarding general psychoderm. And this is why I am probably here today. And at the very beginning, we mostly present some case reports, but now we are more focused on some, performing some clinical studies. But still, it's a rare disease, and we need more and more data. So generally, as a dermatologist, I am focusing with, or I am facing with patients with sometimes with some psychiatric condition, which are not particularly treated by psychiatrists. So because patients usually do not go to a psychiatrist, but they go to dermatologists because they believe they have a skin disease. And as a number one is just delusional infestation. And this is also probably you already heard it from previous speakers, that it's really difficult to convince the patient to go with this particular entity to go to the psychiatrist. But it's, I would say it's really maybe not mandatory, but you have to have a close cooperation with a psychiatrist in order to properly treat this patient. Today, I would like just to talk about comorbidities and also to show you that there are different subtypes of delusional infestation. But if you look in the literature, you may find this disease under different terms. Today, we mostly use delusional of parasitosis or delusional parasitosis or delusional infestation as a common term for these conditions. But in the past, or even today, sometimes you may find, for instance, Ekbom syndrome, which is the same disease, but under different names. So if you look in the literature, you must be very careful which term you use in order to somehow find the proper literature data. So it's maybe a little bit a repetition of the previous talks, but I would like just to introduce the disease again. So if you think about delusional parasitosis, this is a relatively rare disease, or at least infrequent. But on the other hand, I think that there is also the diagnosis is also so the awareness of delusional parasitosis not only among dermatologists but also among other specialties is maybe not so wide. So I think that the prevalence probably is higher than the data are presented, but still is quite uncommon. And this disease is characterized by an unshaken and fixed false belief about parasite infestation of the skin, despite the absence of any medical evidence that that can be somehow supporting this false thoughts. So as I mentioned, this is a rather rare disease. The annual incidence rate is estimated as about 17 cases per million inhabitants. Of course, it may differ in different countries. And the annual prevalence, of course, it's higher. It's more than 80 cases per million inhabitants. So, but still, you must be somehow focus on this disease just to properly diagnose patient in the on the right time. And this disease is probably it's more common in women, and this is estimated that women suffer from this disease 2.5 times more frequently than men. But it doesn't mean that the men do not have this disease. I have many male patients suffering from delusional infestation. So when the patient is coming to your office and you have a suspicion that maybe this patient is suffering from delusional parasitosis, first of all, you have to, of course, exclude that this is a true infestation. And I remember once when I was called to first aid unit, and on phone there was information that the man is saying that every hair follicle is infested with a parasite, and I thought it has to be, or it had to be delusional parasitosis. But I took my dermatoscope and then I look, and it was a true observation from the patient that because there was a lice, and I really could detect the pubic lice in every hair follicle on the lower leg. So it was really surprising for us, but it wasn't the delusional parasitosis. So first of all, you have to exclude this possibility that indeed the patient may suffer from parasitosis. And then if there's no parasite detected, then of course you may think about the presence of delusions of parasite present in the skin. So, and if it is a delusion, then of course this is a delusional parasitosis. And if not, then you should probably consider other diseases. But making the diagnosis of delusional parasitosis is just a first step. And why? Because we have different subtypes. We may have a primary delusion of infestation. That means that the patient has the delusion of being infested with parasite, but there is no other psychiatric condition in this patient. As well, there is no other organic disorder in this patient. Then we may have so-called secondary functional delusion of infestation. It means that the patient has, of course, delusional infestation, but the patient has also suffering from other psychiatric condition, and this other, like for instance schizophrenia, is just a background for this delusional infestation. And then we may have so-called secondary organic delusion of infestation. That means that this let's say false belief is caused by the organic disease, like it can be, for instance, renal failure, whatever. I will come to this later. So we still don't know exactly what's happened in the patient brain. So what is the underlying mechanism involved in delusion of infestation? So this is why it's so difficult to say whether we have a disease which is a comorbid disease, or whether we have a patient with a comorbid disease which is really somehow involved in development of delusional parasitosis. So it was suggested that delusion of infestation may be linked with deteriorated functioning of striatal dopamine transporter, which also corresponds to an increased extracellular dopamine level. And for that reason, this disease or this particular problem, psychiatric condition, may be also induced by some drugs, some medication that inhibit presynaptic dopamine reuptake at the dopamine transporter, like for instance cocaine. Abuser may suffer from delusional parasitosis, as of course it's a secondary to this cocaine abuse. The same regarding amphetamines, the same regarding some drugs like pemolene, methylphenidate. All these drugs can induce the symptoms of delusional infestation, such as, for instance, formication. On the other hand, antipsychotics could improve the symptoms of delusional parasitosis in the majority of patients by decreasing the abnormally high dopamine transmission in the brain. So this is a flow how we should treat the patient, or how we should manage the patient with suspicion of delusional parasitosis. And if you would like just to differentiate between primary and secondary delusional parasitosis, of course you have to really carefully examine the patient. And of course, you should start first with detailed medical history. So it's really important to know about any kind of a recent tropical vacation. It's really important to know anything about the previous history of psychiatric disorders. We also have to look for some systemic disorders like systemic lupus erythematosus, liver failure, renal failure, some endocrine diseases. I will show you some case description, which would be somehow connected with an endocrine disease, and that finally this patient developed delusional infestation. Some tumors, some neurological disorders may also be linked somehow with delusional infestation. Then it's also important to ask whether these symptoms that you can observe in your patient are also present in some family members. I will come to this later. And then, of course, drug abusers are also an important issue. So we have also to ask about the drug abuse history, whether the patient took amphetamines in the past, whether the patient took for instance, cocaine. And then some medication may also be somehow linked to delusional parasitosis. And then you have some examples like anticholinergic drugs, some dopamine agonists, even some ACE inhibitors, and even sometimes some antibiotics. And this is what probably has been already discussed, the common matchbox sign. And now it's more often called as a specimen sign because we are not using any more matchboxes to collect the specimens. But this is what the patient is bringing usually to you. And there are some examples from my office. You can see all the samples. They are just a kind of a proof that this is indeed a kind of a parasitic infestation in the patient. Of course, if you examine this even under the microscope, you cannot find any proof that this is a kind of a parasite. And some more examples of this specific sign, which is very common, very typical. It's not a must, but usually most of the patients bring some specimens just to prove this disease. And specimen sign is it's something that the patient brings to the physician office. Different containers that may contain various dust particles, pieces of the skin. What was found on the skin is just put into this containers, and is brought to you during this consultation. There are different names. Previously, we used a matchbox sign because we use matchboxes very commonly in our daily life. Now it's a history already, but now commonly, as I already mentioned, we use the term specimen sign. Sometimes I also ask my patient to draw this kind of a parasite, and there are just some drawings from my patient. So you can see they can be quite interesting how they can look like, but it's really very helpful that the patient can draw something like that. Then you have a kind of a proof in your documentation that indeed this is something which is really in the patient's mind. And then when we ask our patient what they think about what is going on in the body, most of them said that they have worms. Some that they mentioned parasites. Some of them were not able just to clearly define what it is. They say that they have something in the skin. They may have flies, spiders as well. So these are some examples of the patient, and you can see a lot of scratch marks and some scars in this patient. Of course, it's not necessary that you will see something on the skin, but usually the patient will try to excoriate, to remove the parasites from the body, and there are some more examples of this particular behavior. And then I will come back to this classification. So first of all, you make a diagnosis of delusional parasitosis. Then you have to think whether this is a primary disease or a secondary to some other common medical problems in this patient. And then let's start with secondary functional delusional parasitosis, which is somehow interconnected with some psychiatric condition. We may have schizophrenia, we may have depression, we may have dementia, anxiety, and we may also have a cocaine abusers. On the other hand, we may have this organic delusion of parasitosis, and some examples like anemia, vitamin B12 deficiency, hepatitis, diabetes, hypothyroidism, so some endocrine diseases, and also some infections may also be linked to this underlying cause of delusional parasitosis. And then I will later come to also to shared delusion of parasitosis, which is called also delusional parasitosis folie à deux, that the patient is somehow sharing these delusions to other family members. So this is again how we should proceed with the patient. So first of all, we have to define the diagnosis that this is really a delusional parasitosis or delusional infestation. Then we have to look whether we have a kind of a mental disorder that can be somehow that can explaining this problem. So then we may have secondary functional delusional parasitosis. Then if no, there's a question whether you have a kind of an organic disorder, like for instance diabetes. If it is true, then we must somehow think, can we link this disease which is present in the patient? Because you know, elderly people may suffer from different systemic diseases, but not all the diseases may be linked or are necessarily linked to delusional infestation. But if we think it is a possibility, such a possibility, then we may, of course, we have to consider this is a secondary organic delusional infestation. And then if no, so if you have a pure or primary delusional parasitosis, then is a question now whether we have the same symptoms in other members of the family. And if no, then we may diagnose primary delusional parasitosis. If yes, then we have to think who was first, and whether the symptoms appeared in other family members before this particular patient started to have this kind of delusions, or maybe our patient was the first. When our patient was the first, then we have still primary delusional parasitosis, and if not, then we may diagnose so-called shared delusional parasitosis, which is commonly named, like for instance, delusional infestation folie à deux, or even some other names are used, and I will come to this also later. Okay, just a second, and this is a table from you may see from a very nice case description. I will present this later, described from the students from Mayo Clinic, and they just give an overview, a very detailed overview, what kind of possible reasons we may have for secondary delusional parasitosis, but not only for secondary delusional parasitosis, but also for generalized pruritus. Because sometimes the patient may suffer from some sensations and they cannot explain why the patient is suffering from that. So the patient may suffer from pruritus, and then finally he tried to explain it, and one of the explanation may be a kind of a parasitosis. So you have different, you see different possibilities, like you may have a dermatologic condition. I already mentioned like psychiatric conditions. You may also have some hematologic or oncologic diseases, like for instance, severe anemia, lymphoproliferative disorders, some lymphomas, and even some solid cancers may also be linked with chronic pruritus, which may finally produce delusional infestation. Then we may have metabolic diseases, like for instance, uremia, cholestasis, or carcinoid syndrome. We may have endocrine diseases, already mentioned diabetes, but also hyper and hypothyroidism, and also hyper and hypoparathyroidism. Then already mentioned substance abuse, like cocaine, amphetamines, and also sometimes in patients that stop drink alcohol may have such symptoms. Then some infections, and again, some diseases which are interconnected or connected with the nerve system, but in this particular situation, neurologic diseases. And it's sometimes difficult to distinguish whether, especially for instance, in very advanced neurologic conditions, like in advanced Parkinson's disease, in advanced Huntington disease, whether there's a pure neurologic condition, or maybe already we also have some psychiatric problems. And this is one of the patients. We already published this case report. This was a patient with chronic renal failure, and 2 years after he started hemodialysis, the patient developed symptoms of delusional infestation, and there was no previous psychiatric anamnesis in this patient. As you may see, this patient presented with delusional thoughts. He was bitten by a spider, which put its eggs into the skin. The butterflies were formed from these eggs, and the insects were present in the stool and in nasal secretion. Okay, having this kind of a description, we have a suspicion of delusional parasitosis. The patient also had insomnia and refused to eat, as the food products, in his opinion, created the culture medium for new insects. And then we finally, of course, diagnose delusional parasitosis. We put this patient on risperidone, 2 milligrams per day, and we really have some improvement of symptoms, but fortunately, the patient, after a couple of weeks, stopped the treatment and was not present for any further consultation. And then I would like us to show this case because we have a patient with chronic renal failure on hemodialysis. We have who developed delusional infestation. So we still cannot clearly say that this is a secondary case of delusional parasitosis, but still there is a kind of an interaction between these two diseases. From one hand, we may have as a kind of a symptom of chronic renal failure, we may have chronic pruritus, and based on this chronic pruritus, the patient may have false beliefs that the skin is infested by some parasites, and this is the reason why the patient is suffering from pruritus. On the other hand, if you have a number of comorbidities, sometimes it's really difficult to start the treatment because all these all these neuroleptics are also not very safe drugs, especially in elderly people. So you must be quite careful. Okay, and then I would like to show you some details about so-called shared delusional parasitosis. And this is, you already had this specimen sign before, but there are 2 bottles. And why 2? Because these bottles came from 2 people living together, and one person started this or was the first person who was suffering from delusional parasitosis, and then the family member also started to believe that he was infested by a parasite. So in this particular situation, the first symptoms were present in the woman, and then subsequently the man, the husband, also developed this kind of a false thoughts. And this is another example, and you see more containers because it was like a whole family was sharing, or were sharing, the whole was sharing all this, let's say, delusion of infestations. The first symptoms appeared in the grandmother, but then all the daughters of this grandmother start to scratch and start to believe that they are also infested, and all of them bring to me this nice specimen signs. There was only the brother of the sisters didn't suffer from any symptoms of delusional parasitosis, so that may happen. So then we may have this shared delusional parasitosis. If only one person is sharing the symptoms, then we say that this is the delusional infestation folie deux. If more than one or the whole family is sharing the symptoms, then we may say that we may have that we are having delusional infestation folie familia. And you'll see that this phenomenon is not so rare. About 5 to 15 cases diagnosed with delusional infestation to really have this kind of shared delusional infestation. And if you separate this particular patient from the, let's say, previous or from the primary patient, sometimes these symptoms of delusional parasitosis may disappear spontaneously, but usually also these people require some psychotherapy and pharmacotherapy just to clear the symptoms. And usually, if you separate this person from the other family members, it's much faster just to achieve the clinical improvement. And risk factors for secondary cases developing shared delusional infestation include living in close proximity or having a very close relationship to an index patient affected by delusional infestation. Then female sex is also a kind of a risk factor, and social isolation due to language or culture. So for instance, in the United States, if you have foreigners and within this, let's say foreigners, there is one person who is suffering from delusional infestation, then also the other, let's say close relatives are more prone to develop delusional infestation because they feel somehow isolated from the society. So leaving the primary patient, so separate to separate the secondary patients may cause patient delusion to be more recalcitrant to treatment. And this is also very important. The resolution of the primary cases, delusions, and symptoms can often result in significant improvement for the secondary case, even without further treatment. So it is really important to find who is the first patient, and this is very important to start the treatment of this first of this first, I would say, index person. And then I would like just to show you a nice case description which was just present, as I mentioned already, from the students from Mayo Clinic. And this is a case of so-called iatrogenic delusional parasitosis. And these students, they describe a female patient who suffered from pruritus of the scalp. And for that reason, he sought for physician help. And then she went to the doctors, to two different doctors. And one doctor diagnosed lice, even without any, documentation for that. And the other doctor diagnosed a mite infestation without having any proof for that, and prescribed antiparasitic therapy, which of course was ineffective. However, after 2 months, she finally saw a dermatologist who discerned no evidence of lice. Despite her insistence, she had them propose delusional parasitosis diagnosis, which was confirmed by subsequently by a psychiatrist, and the patient was put on a kind of a neuroleptic Pimozid. And later, the dermatologist noticed previous elevated serum calcium levels, and when a repeated calcium level was still elevated, this physician, this dermatologist, consulted an endocrinologist who quickly diagnosed primary hyperparathyroidism with hypercalcemia-induced itching. So a month after parathyroidectomy, the patient did better. Several months later, without Pimozid, without any topical agents, she endorsed neither itching nor delusions. And then she eventually recalled that the urgent care doctors, rather than she, first thought she had bugs. They said it is my mind that it might be a parasite, she said. If a doctor said it must be true. So, and in this particular case, we indeed have a kind of a secondary orogenic delusional parasitosis because we have this not diagnosed parathyroidism with this hypercalcemia. And this was the primary cause of this itching, which can then subsequently produce this delusional infestation symptoms. So what we should do if we suspect a secondary cause of delusional parasitosis, we of course have to do a number of laboratory tests. So you have this complete blood count and differential, liver function test, steroid function test. Of course, we have to look for serum electrolytes, calcium, glucose level, urea, nitrogen, also for creatinine, because also renal failure may be somehow interrelated. Then we have to look for some vitamins like folates, vitamin B12, iron study assessment should also be done, urine analysis, urine toxic screen, and then we also have to look if the patient is not having any kind of a malignancy. And then finally, I would like us to finish with so-called delusional infestation by proxy. This is a rather rare form of delusional infestation. In this form of delusional infestation, the primary patient, usually this is a dominant psychotic individual, believes that someone close to him, not particularly he, such as her child or a relative or even a pet, but not himself or herself, is infested with pathogens. And that the dependents do not necessarily share the same delusion, at least at the beginning, but they become subjected to the dominant psychotic individual's idiosyncratically devised intervention. So you must remember about this very unusual, especially form of delusional infestation, especially if you consider children. And then sometimes you have to call the other officers just to separate even the child from the mother or father, who is somehow a reason for this per proxy delusional infestation. So then I would like us to conclude with some take-home messages. First of all, delusional of infestation is really a psychotic disorder characterized by an unshaken or fixed false belief about parasite infestation of the skin, despite the absence of any medical evidence that could support this claim. Delusions of infestation could be distinguished into primary, secondary to other psychiatric disorder, or organic form, secondary to organic disease, and close multidisciplinary cooperation between clinicians, especially dermatologists and psychiatrists, but not only these specialties should be involved, is really fundamental to shorten the time of diagnosis and to investigate the proper and to instigate the proper treatment. So this is my city. So you are warmly welcome to come to Poland and to see Rzeszów as well. And then I would like just to answer any questions you have regarding my presentation. Thank you very much.
So Adam, are you going to be around for the Q&A at the end? I know you.
What time? What time?
It will start in about an hour, and it's only for a half hour.
Yeah, so I will try.
Okay.
I am here. Yeah, no problem.
Okay, sounds good. All right, well, thank you very much. Does anybody have a question for him before he signs off? All right, thank you again.
Thank you.
Okay, this next talk is a pre-recorded video. Dr. Koo was unable to make it today. He is actually in Hawaii doing another program, but Dr. John Koo is a dermatologist and the director of the UCSF Psoriasis and Skin Treatment Center. His research interests include psoriasis therapies, phototherapy, eczema, psychodermatology, and quality of life issues. So he earned his medical degree from Harvard University. He completed a residency in psychiatry at the University of California, Los Angeles, followed by a residency in dermatology at UCSF. So he serves on the editorial board for the Journal of American Academy of Dermatology. So his talk this afternoon is going to be on practical psychodermatology and treatment. So let me get set up for us. Share.
I am a professor of dermatology at UCSF Department of Dermatology in San Francisco. I'm also board certified in psychiatry and dermatology. And thank you for joining me. I'm going to be talking about practical psychodermatology. And the reason I think this is important lecture, hopefully for you, is because for some of you, I'm not even sure if you ever get any lecture on psychodermatology in your entire residency. And this is because the number of people who are both expert in psychodermatology and happy to see these types of patients, including delusional patients, probably less than the number of fingers in your two hands across US. And there's 143 dermatology residency program, only 2 of them has somebody who is a faculty who's board certified in psychiatry and dermatology. So psychodermatology is something that I think is very important in your practice, but you might not have too much opportunity to learn about. Even American Academy of Dermatology meeting, the last live meeting we had, 2019 AAD, there was 343 sessions offered, and only 1 set of those sessions were about psychodermatology. And a lot of this is because, once again, there's not that many people who are specialized in psychodermatology and happy to teach as well as see these kind of patients. So what I'm going to try to do is to give you overview of psychodermatology. The first part, I'm just going to give you a taste of what psychodermatology consists of, because it's a whole field, it's not one disease. And then the last part, I'm going to focus in detail on how to manage patients with delusions of parasitosis, which is also called delusional infestation, or Morgellons disease, because that's one condition that is very difficult for every practitioner, and it's not an uncommon condition. So all of you, sooner or later, will probably have to deal with these patients if you haven't already. So let me go ahead and get started. I have no conflict of interest because there is no sponsor for psychodermatology to have conflict of interest with. Now, this is a cartoon where somebody's about to jump off a building, and there's a policeman with a dermatologist. And the caption, which got cut off, said, "We cannot find a psychiatrist, but we found a dermatologist. Do you have anything wrong with your skin?" And this is the kind of situation that happens frequently in our practice when we visit a patient, such as with delusions of parasitosis, go to see a psychiatrist or at least some kind of a mental health professional, but in fact, they want to come see us instead. Oh, by the way, if any of you ever wonder who is Dr. Nicholas Brownstone, whose picture you see right below me, he's my fellow, and he's helping me to do this whole thing, including to record this lecture. Now, psychodermatology, as I mentioned, is not one disease, but a whole field. Probably the most common condition is skin disorders precipitated or exacerbated by stress. And that includes psoriasis, atopic dermatitis, acne. Sometimes I feel that almost any inflammatory condition of the skin can be worsened by stress. But even some non-inflammatory condition, or at least not inflammation visible to the eyes, such as alopecia areata, are thought to be also caused by stress in some patients. And then there's a psychological impact of disfigurement. Because skin is visible, many patients feel awful, their self-esteem is devastated, their body image suffers, and people can end up with depression, anxiety, social phobia. There are also people who have psychogenic excoriations, delusions of parasitosis, even pruritus, which is the #1 symptom in dermatology. How miserable people are has a lot to do with the patient's mental status. And personality disorder might also be important, especially if you do cosmetic procedures as part of your practice. Because there are so many different conditions, it is good to separate apples from orange. And this is how I do it. Psychodermatological conditions come in 4 different big categories. First, psychophysiologic disorders, which is on the left. That is skin conditions that are real, but can be frequently exacerbated or even precipitated by stress. Second, primary psychiatric disorders. These are people whose problem is primarily psychiatric, there's nothing really wrong with their skin, hair, or nail. And these are the people with delusions of parasitosis, factitious dermatitis, psychogenic excoriation, and so forth. Third is the secondary psychiatric disorder. These are people who suffer emotional, social, sometimes even occupational damage by the fact that they have skin disease, real skin disease. And then lastly, cutaneous sensory disorders. There are many patients who come to dermatologists with sensations on the skin ranging from crawling and biting, burning, electric shock kind of sensations, all kinds of disagreeable sensations. And a lot of times neurologists give up on these people and then end up coming to dermatologists. Traditional dermatology remedies like topical steroids generally don't do much. However, the use of things like Neurontin or tricyclic antidepressants tend to be helpful. So those are different categories of psychodermatological conditions. On the other hand, the other way to understand psychodermatology is the nature of underlying psychiatric problem. And most of these, the best way to find out is just ask. Are you anxious? Are you depressed? Do you have obsessive compulsive tendency? Now, the fourth one, psychosis. You really cannot ask, are you psychotic? Because people who are psychotic typically have very little insight and they don't know that they're psychotic or delusional. So psychosis, you have to be very diplomatic. And lastly, personality disorders, once again, which is important, especially in cosmetic practice, borderline narcissistic personality disorders. So psychophysiologic disorders, people with psoriasis, people with atopic dermatitis, many people report that stress may get worse. There was a study done by Dr. Grismere decades ago, documenting what % of patients reported that emotional trigger was important in the natural course of their skin disease. And as you can see, hyperhidrosis, it's like 100%. Lichen simplex chronicus, 98% of the patients said stress was important. Psoriasis, 62%, with different incubation time. The building in the front is UCSF Psoriasis Treatment Center, where I'm a director. And this is where we do Geckerman treatment for psoriasis, atopic dermatitis, generalized prurigo nodularis. Believe it or not, we still do this treatment. But the other part of the treatment is like relaxation, because many of these people do find relief when they learn to relax more effectively. This is a patient with hyperhidrosis who failed many usual treatments. And then eventually the case was referred to me because the last dermatologist he was seeing realized that the patient was having this sweating attack secondary to anxiety attacks. So we really could not help the patient unless somebody do something about his anxiety attack. So I started him on alprazolam. The old brand name is Xanax, and his sweating attack improved greatly, but he was still having a little breakthrough sweating attacks because he was having little breakthrough anxiety attacks, since medications like alprazolam only works for a couple hours. If he forget to take the next dose, he could have another attack. So I added a low dose of doxepin, like 25 milligrams per day. And low-dose doxepin works very much like anti-anxiety agent without being addictive. So on those two medications, his hyperhidrosis was completely under control. Eventually, I was able to wean off both medications without recurrence. So sometimes you just have to find out what's causing the problem as opposed to just looking at the skin. Buspirone, Buspar, this is one of the most benign medication any dermatologist can try his or her on in terms of psychopharmacology. The usual dose is 5 to 10 milligrams twice a day to 4 times a day. This is a non-sedating anti-anxiety agent that is also non-addictive. the side effects are quite rare, and I cannot think of any serious side effect with buspirone, but it takes about a month for the anti-anxiety effect to kick in. So the patient needs to be patient when they are prescribed alprazolam. I'm sorry, the buspirone. Now, alprazolam or Xanax, this is much more quick-acting benzodiazepine, and the dosing to be very conservative, because I can totally understand if you feel nervous about using any of these medications. Start with 0.25 milligram. That's the smallest dose available. You can even have the patient cut it in half. So half of 0.25 milligram is 0.125 milligram. And it could be used like 3 times a day, and gradually increase the dose, titrate up by as little as 0.125, which is half a tablet, or 0.25 milligram, until you find the dose that actually cut the anxiety seriously down, but not make the patient sedated. Now, alprazolam is a medication that can be addictive because it's benzodiazepine. So as soon as the anxiety is under control, and eventually then slowly think about planning to taper the patient off. Now, paroxetine, Taxil, and that's a SSRI, antidepressant, but it's also anti-anxiety agent in the dose of 10 to 20 milligrams per day. Is also a good anti-anxiety agent, and it has official FDA approval for that. Now, primary psychiatric disorders, this is where the main condition is psychiatric. There is really no skin problem, no nail problem, no hair problem. Some of them are caused by depression. Sometimes when people are really depressed, they get agitated instead of having retarded depression. Agitated depression means people become restless. They become cranky. And then those people sometimes pick on their skin. This is an example of somebody who was very depressed, but more agitated. And this is another lady who was also depressed and was picking on her skin. Now, you notice that there is a sparing of the skin on both sides of her back, almost like in the shape of the wing of butterfly. Sometimes this is referred to as butterfly sign. And this is because those are the areas that people have hard time reaching. Real skin disease doesn't care if you can reach or not, whereas the self-induced lesions tend to occur mostly on an easily reachable area. For example, extensor side of the arm, you often see the lesions. You rarely see the lesions in the medial aspect of the arm. If it were leg, you often see lesions on the extensor and the anterior part of the leg. Almost nobody pick like the posterior part of the leg, especially the upper leg. It's just too awkward to do that. And this is the same patient that you saw earlier after being treated with doxepin. Now, doxepin is widely used by dermatologists in low dose, but in higher dose of 100 milligrams per day or higher, it's an antidepressant. And not only that, it has tremendous anti-itch effect. And also, one of the problems with depression is insomnia. Doxepin also tends to help with insomnia. So when the patient is successfully treated, and this lady was treated with doxepin 100 milligrams per day at bedtime, and she was okay with the sedation, which is the #1 side effect of doxepin. Eventually, she stopped picking on her skin, because when patients recover from depression, oftentimes they find that picking is too painful. There's a theory that when people are depressed, endorphins, which is one of the stress hormones, can go up in some people, which might make those people indifferent to pain, so they can make holes on themselves. But once they are recovered from depression, it's too painful. They can't do it anymore. So doxepin, often starting dose is very low because sedation is a possibility, 10 milligrams at bedtime. And then you can gradually titrate the medication up. Now, the usual antidepressant dose is 100 milligrams a day or higher. for ordinary adults, although it might be lower in elderly. And FDA approved doses up to 300 milligrams per day. Why? It's because there is a huge variation in the metabolism of doxepin. There are some hypermetabolizers where you really need to use very high dose in order to get a good blood dose. And the good thing is that serum doxepin level is available commercially. You might have to look for it, but every lab does that. And what you get is doxepin and no doxepin, NOR doxepin, which is the only active metabolite. And if the blood level, which is trough blood level, at least 12 hours after the last oral dose of doxepin, trough blood level is within therapeutic range, then you are fine. Now, in people who are older, it's also good to check EKG. This is one case that I have published in the Journal of American Academy of Dermatology. Older patient who was using doxepin not for depression, but for pruritus, scalp pruritus. And he failed like 40 different treatment modalities, both orthodox and alternative medicine. And what this is showing is that as the doxepin level dose go up higher, he almost made it to 300 milligrams per day. His blood level in yellow was not very good at all until we hit about higher than 250 milligrams. Finally, his blood level went up. And to my knowledge, this patient was compliant all along. So he's like a hypermetabolizer, and his scalp pruritus, which has been tormenting him for years, actually disappeared. So that's the therapeutic level of doxepin in our lab. And in order to get to that, we had to slowly titrate the dose using the trough blood level as a guide. And of course, we only go up provided the patient have no side effect. But sometimes you have to push the dose and individualize it in order to make doxepin do its therapeutic effect. Now, in terms of antidepressant, there are many antidepressants available. My favorite actually is paroxetine or Paxil, because paroxetine is more relaxing, whereas fluoxetine or Prozac is more activating, more sometimes anxiety provoking when you start. And sertraline or Zoloft, it's neither activating nor sedating. So I tend to use paroxetine if it's mainly for depression, but doxepin if itching is part of the big picture. Now, obsessive compulsive disorder. Obsession is intrusive thoughts. Compulsion is the behavioral component of OCD. So, in dermatology, we have all kinds of compulsion. To pick on the skin, pull out the hair, and acetylcysteine. This is over-the-counter dietary supplement, and used according to the direction. It can help the obsessive compulsive tendency, including picking, pulling hair, and so forth. The possible side effect is mainly the GI side effect, abdominal discomfort. Now, paroxetine not only is FDA approved for depression and anxiety, but also it's anti-compulsive. Only thing is, to use it as anti-compulsive agent, you often need a higher dose, up to 80 milligrams per day. And side effects include sedation, sexual dysfunction, GI discomfort, and weight gain. Now, secondary psychiatric disorder, this is where because of the embarrassing appearance of ugly skin disease, people become depressed, anxious, social phobic, and so forth. Now, because of the limitation in time, I won't go into the detail, but it's good to be aware of that part of it. Cutaneous sensory disorder. This is a very nice man who had tremendous attack of itching, which failed many treatments. He's been to Mayo Clinic, he's been to Stanford, all kinds of treatments, including intralesional steroid and so forth. Mondoxapine, his itching completely disappeared. And if I stop doxapine abruptly, the itching comes back. This is central nervous system mediated pruritus. Now, when we have cutaneous sensory syndrome, gabapentin is one of the safer medications to use, the Neurontin. But the second line, tricyclic antidepressant, relatively low dose, lower dose than what we usually use for depression, anywhere from 10 milligrams per day to maybe about up to 50 milligrams per day. If the itch is the main problem, doxapine is usually a good choice. If the pain is the problem, amitriptyline, the old brand name of Elavil, actually has the most data. However, amitriptyline is not always tolerated. If it's not tolerated, then the newer tricyclics such as desipramine or norpramine is used. And then if that is somehow not tolerated or does not work, then non-tricyclics such as SSRI can be used for cutaneous dysesthesia. Amitriptyline, I don't use it as much because even though most studies were done for cutaneous analgesic effect with amitriptyline, it has the most side effect. Desipramine, which is a metabolite of amitriptyline, so much better tolerated. Once again, the dosage is 10 to 50 milligrams daily. Now, personality disorder. It's well known that cosmetic practice, many of the patients has borderline personality or narcissistic personality disorder. It's really important to know how to recognize these personality disorders, because if you don't know who you are dealing with, these people can wreak havoc to your practice. Now, finally, before I run out of time, I would like to cover psychosis. And this, I'm gonna spend more time and go into more detail, because Morgellons patients or people with delusions of parasitosis, delusional infestation, I think that's one of the biggest tragedy in dermatology, because many of these patients probably do not get the care that they need. And it's not anybody's fault, really. It's the disease that is driving these people to a wrong specialist, if I may say so, meaning to the dermatologist. And so I like to spend some time on talking about how to help these people. Now, lady put this on my desk and say, these are the parasites. I look at it and then I couldn't see anything. So I said, I'm sorry, I couldn't see anything. I just see water. And then she looked at me and said, of course you only see water. These parasites are invisible. You know, so the point is, if somebody is truly delusional, you can't argue with them. And the kind of the psychosis we see as dermatologists most often is monosymptomatic hypochondriacal psychosis. This is a terminology that's actually used more in Europe, but I think it's really a good spot-on kind of a terminology, because these people really tend to have monosymptomatic psychosis. In psychiatry, it's also called encapsulated delusion. It's almost like a craziness in a capsule, which is very different than something like schizophrenia. Schizophrenia is a multi-deficit problem where people not only have wrong idea, delusional idea, but they also typically see things, hear things. Schizophrenic patients tend to have flat affect or inappropriate affect, or people who become schizophrenic lose their social skill. So schizophrenia, in contrast, it is a more global deficit. You know, whereas delusions of parasitosis or Morgellons syndrome, they tend to be much more focal. And the rest of the personality, the rest of psychological function is largely normal, which is actually nice for me, because once you learn how to connect with these people, in honesty, I have to say they're delightful people. They're not like that stereotype chronic psychiatric patient where you can tell something's wrong even if you are like 20 feet away. These people really have a focal problem. Now, not everybody talks about parasite. If they talk about parasite and they don't have any, then we generally use the term delusions of parasitosis. If they talk about foreign materials coming out of the skin, like blue fiber or black dots or white dots, we tend to use the word Morgellons disease. But people can have all kinds of delusions. Some people might think that they are too greasy or they're losing hair. So now, with all these encapsulated or sharply defined delusional problem, one very critical step is to distinguish between primary delusions of parasitosis, DOP stands for delusions of parasitosis, versus secondary delusions of parasitosis. The reason is that the primary delusions of parasitosis, where the condition occurs spontaneously, that's the kind that we really should be trying to take care of, because these people, practically none of them want to go see a psychiatrist. And the other thing is, primary delusions of parasitosis, the spontaneous cases, are overwhelmingly older women worldwide. Whereas secondary delusions of parasitosis means delusion is secondary to other things like drug use, like other medical or psychiatric illness, dementia, schizophrenia, manic depressive, psychosis, and so forth. To deal with secondary delusions of parasitosis, you really need a whole department of psychiatry, because what you have to do all depends on what the delusion is secondary to. In fact, even me as a psychiatrist will not try to handle secondary cases in the dermatology department, because there's no way I can be a one-person psych department. So I'm going to primarily talk about primary delusions of parasitosis. And officially, only primary delusion of parasitosis is recognized as delusions of parasitosis, because according to the DSM-5, if the delusion about parasite or foreign material is secondary to some other broader condition, such as dementia or schizophrenia or drug use, then we are not supposed to call that delusions of parasitosis. We're supposed to focus on the underlying problem that's causing it. Now, the thing about primary or spontaneous delusions of parasitosis, why is it mostly women? Not only why is it mostly women, why is it mostly older women? And there is an interesting work that is going on in Europe that suggests that this condition might impact the organic. And one of the more interesting theory with some functional MRI evidence is that there is a system called DAT system, which you see on the right. That stands for dopamine transport system. Now, dopamine transport system is most prominent in women, not men. And it keeps the dopamine in the brain in reasonably good range. Now, that system, it depends on proper and adequate level of estrogen to function. And as the women get older and estrogen level goes down, then this DAT system in some women might actually become less functional. People end up with too much dopamine because they are not as well regulated, and they might end up with psychosis. So this is just graphically showing what's on the left is what's supposed to be the proper amount of doxepin, whereas on the right you see excessive dopamine, which can lead to excessive and inappropriate dopamine mediated neurotransmission in the brain, resulting in both tactile hallucinosis as well as delusional ideation. And if this process involves the part of the brain that is important for transmission of sensation in the skin, then people are more likely to develop delusions of parasitosis. And then at the same time, they can also have the same kind of dysfunction in the frontal lobe. And frontal lobe is important for proper judgment. So people who have frontal lobe compromise, even if they were given clear logical explanation and evidence that they don't have parasite, they might not be able to accept that or understand or comprehend when the frontal lobe is involved. So this is one of my more recent article. Is Morgan-Lenz disease an organic disease? And this primarily summarized the structural and functional brain abnormality, which has been found after many people with delusional parasitosis actually cooperated with studying their brain. And frontal striato-thalamo-parietal dysfunction. These are the, and we're talking about areas that are involved in transmission of skin sensation. And as you can see, there are many different pathologies which can be found in these patients, as well as I said, the frontal lobe deficit. And this is important because many of these patients feel that they are not given proper respect. And I hate to think that any of us in dermatology would not give proper respect to the patients, but I think that there is a possibility that if some condition is thought to be purely psychological, then they may not get as much respect as conditions that we know is physically caused. And if these theories are correct, which I personally think that it's likely to be, delusions of parasitosis might be just as organic condition as catching a cold. But the other thing is that this process is gradual in many people. They're not always absolutely delusional when they start. And this is one of my paper about the spectrum of ideation in patients with symptoms of infestation. Now, what I'm trying to say is that in my 35 plus years of experience, many of these people start with formication only. Formication, of course, means crawling, biting, stinging sensation. And then they can, over time, begin to be very much more worried about this formication, start to think about it a lot, getting more mentally preoccupied, so they could end up with the third stage that I show here, overvalued idea, but they're still not completely rigid. And then beyond that, they can actually become delusionoid, which means almost delusional. In fact, when they come in, delusionoid patients and delusional patients might look almost identical. And then if you get into argument with them or some kind of a conflict, then it's really hard to tell them apart. The way to tell them apart is if I can actually have good rapport established with these patients and we really get along, then I would think about the possibility of asking the question, how important is it that your condition is actually caused by living thing? Or do you just want to get rid of this condition so you can live happy, normal life? And if they can articulate that, oh, it doesn't matter whether it's caused by living thing, even though I'm really worried about parasites and so forth, I don't care what it is. I just want to get rid of it. If somebody can say that, then technically they're not delusional. However, the next step is to actually become delusional, where only the ideas about parasite or blue fiber or whatever is acceptable. Any other suggestion, they will resent it. But even delusional patients, where we have to be more careful as a provider in terms of how we talk to them, so we don't get them in a bad mood. Even those cases, in my experience, most of them still can accept antipsychotic medication as long as we don't present it as antipsychotic medication, and they can still get better. Why? Because they still want to be better. They don't want to live like this. Now, rare patients, a real unfortunate case, have terminal delusion where they don't care about anything except for us to believe in them. It's almost like a religious extremist or something like that. Now, terminal delusion patients, even I have a hard time doing anything for them. Now, how to manage these patients? Pimozide and Risperidone and some other medications are extremely effective and low dose. So there's hope. Treatment really works. And the thing is, how do we get to take it? Now, you cannot hope to get them to accept the treatment unless you can connect with them. So the thing about these patients is that naturally, I think all of us prefer to see regular patient with actinic keratosis, acne, whatever. But we cannot afford to go in looking unhappy about seeing them. So it's important to give very positive attitude and body language. And don't worry about the medication. Initially, the most important thing is how do we establish rapport. So I have this stop sign, because if I'm told that there's a new one of these delusional patients waiting to see you, sometimes I'm behind myself already on my schedule, and I don't like it. But I dare not go in there with long face, because then things can really go ugly quickly. So I stop myself if I'm not feeling that great. Sometimes I take my two hands and make my face purposely smile. And then I pretend that I'm seeing my favorite Hollywood star, because it's important to start off with a good step, even if you were part of my professional acting. And now, some blood tests, especially what you see in the red, thyroid function test, vitamin B12, tox screen, can be helpful along with the others. But the thing is, if they are fixated on ideology, we really cannot do very much. So initially, I still have to do my due diligence, looking at their specimen, encouraging them to talk to me in detail, examine their skin, to basically gain trust. But on the other hand, eventually I would like to steer them to a pragmatism, to see if they are willing to try medications like antipsychotic on a trial and error basis. So I'm not going to risk instant invalidation by saying that to the patient that, oh, you don't have parasite, oh, don't, it's in your head. That's not gonna work in my experience very well. I rather say you have mysterious condition, and that we really need to get you out of this awful condition. And there are some medications that are known to be helpful. So the way to encourage therapy, the way that I do it, is that at first it looked like they are only interested in validation of their delusional ideation, but in fact, they have another strong wish that drove them into your office, which is their wish to escape from this living hell. They're not having fun. In fact, people with delusional parasitosis on average are so much more miserable than people with whole body psoriasis. As some of you know, my other area of expertise is psoriasis. So they're not having fun at all. They don't like this. So I purposely diminish the thing about validation and further exploration after I do some due diligence in looking at their specimen, looking at their skin. And then I emphasize the importance of escaping from this living hell. They try to be brave, but they're really miserable, and I know that. So I deliberately articulate how awful this condition is, how this is like a living hell. And I find that some patients really get touched by that. They say, "Oh, gee, Dr. Ku, you're the first person who really understands how awful this condition is." A lot of other dermatologists we've seen, they just told me that this is nothing, there's nothing important, and just shoo me out of the office. So, and then, so I purposely motivate them to try oral medications by stimulating their desire to get out of their current misery. And now Pimozide is historically the most commonly used medication, brand name Orap. And I find this medication particularly helpful because it has no psychiatric indication in USA. Its only FDA indication is Tourette syndrome. So I can honestly tell the patient that this is not a medicine FDA approved for psychiatric condition. It's a medicine for Tourette syndrome that has absolutely nothing to do with you. And many people find Pimozide acceptable because of that. Now, I could use antipsychotic medication, risperidone, for example, olanzapine, but unfortunately, they all have psych indication. And nowadays, many patients Google, and then if they find that this is a medication for crazy people, not only they will take it, but their rapport with me can be jeopardized. Now, it is true that Pimozide has higher risk of tardive dyskinesia than the newer medications, but the newer medications also have issues that Pimozide doesn't have, which is risk of creating metabolic syndrome. And last thing is that the Pimozide, as well as the newer medication, works so well that I often need to use very low dose. So tardive dyskinesia is very unlikely because of the low dose that is used, and people generally do not take this medication lifelong, like people with schizophrenia. So worldwide, the whole mankind's history, the number of tardive dyskinesia reported in dermatology setting with Pimozide is only one, and that's after half a century of worldwide use. So dosing, I call it trapezoid dosing. I start with very low dose, 0.5 milligram, which is just a half a tablet of Pimozide. Pimozide is usually exposure, you can just break it in half. And then you go up by every 2 to 4 weeks. And then I would tell the patient ahead of time, don't expect any benefit until we hit 3 milligrams per day at least. Now, many people notice great improvement before they hit 3 milligrams. But I don't want them to give up prematurely. So I tell them, don't worry about if it's working or not until we work up to 3 milligrams by going up by 0.5 milligrams every 2 to 4 weeks. So that's the increasing phase of trapezoid. And somewhere along the way, maybe even before 3 milligrams, they experience great improvement. If they experience great improvement, then I'm not going to insist on going up to 3 milligrams. Whatever the dose that they respond is fine. And then I will keep the effective dose going until their symptom, the chronic biting stinging sensation clears or almost clears, and their mental preoccupation almost always goes down, so they can start enjoying life. Now, after the symptom is virtually gone, I ask them to continue for another 3 to 4 months. Why? Because if I try to discontinue or taper too soon, I find that some patients have recurrence, and that's very discouraging for the patient. So I ask them to continue the same dose 3 or 4 months or longer, because we're typically using very low dose anyway. And by this time, the patients think the Pimozide or Risperidone is godsend. They generally have no objection taking it longer. In fact, they are more afraid that I might take the medicine away from them. And then eventually, when we taper, we go down by the same half a tablet every 2 to 4 weeks, the way we came up. Now, potential side effect of Pimozide, before I talk about that, I have to put it in perspective. My experience, 35 plus years, I cannot remember the last time anybody had any significant side effect. And I think that's probably because we use so ridiculously low dose. And the reason we use ridiculously low dose is because this condition is so responsive to Pimozide, Risperidone, and so forth. But theoretically, stiffness or restlessness can happen. Over-the-counter Benadryl, 25 milligrams up to 4 times a day PRN. Watch out for sedation. That's very effective for stiffness or restlessness. But I cannot remember the last time any of my patients had to take Benadryl. But I always have them carry with them just in case. Sedation and activation, that can happen sometimes. But if it's sedating, take it at that time. If it's activating, have more energy, then take it in the morning. They get more things done. As I said, tardive dyskinesia, only one case reported in dermatology setting after half a century of use. So it's very unlikely. Now, EKG, I think it's good to check if the patient is old. Now, the definition of what is old, I put typically 50 plus. That's been conservative. But basically, it's good to do it anyway. And what you're looking for is increased QT interval and silent arrhythmia. And how many of my patients have those? Practically none, but it's good to check. And then also hypokalemia, hypomagnesemia can cause. So the initial lab, I think it's good to also check these electrolytes in magnesium. Now, alternative to Pimozide, if patient cannot tolerate Pimozide or they're on the medication that there are several medications that are available. Olanzapine, but by far my favorite is Risperidone. The dosing is the same, and also the trapezoid kind of dosing. Higher risk syndrome, lower risk of tardive dyskinesia. So that is the psychosis part of the whole psychodermatology. But I'm hoping that I have given you enough information that you can actually try to give them the treatment they really need, which is antipsychotic, or Pimozide, which is anti. Now, it is in some reference book because chemically it is similar to the other antipsychotic, but once again, in the United States of America, it is not used as an antipsychotic, and we know that there are many anti-nausea pills, for example, and many antihistamines that also have chemical structures similar to antipsychotic, but we don't usually think of icomazine as antipsychotic. So that's, I personally present Pimozide once again as medication with no psychiatric FDA indication. It's Tourette syndrome medication, and Tourette syndrome have nothing to do with them. Now, if anybody face one of these patients, feel like trying to treat them, but I'm a faculty at UCSF, and there is an official UCSF function, which is called UCSF Second Opinion. And there is a one-time fee. I don't think insurance covers this, but patients might find it worthwhile. Then I can officially review the case and then give you guidance and hopefully also give you endorsement on treating this, because I understand dermatologists who have never used Risperidone or olanzapine my field.
So now we're going to move into our Q&A. Okay, we have a question from Pierre Seagart. When we refer the specimen submitter to a doctor, what is our best option for directing them to the care they need? The general practitioner or a dermatologist or someone else?
I say something about that, even though I don't know the medical system in the United States particularly well. I think the general practitioner has pros and cons because they are usually the person who knows the patient best and who they trust the most. And if it's possible to talk to the family doctor up front and they're comfortable enough, then that's probably the best way forward. But if they say, oh, no, I want nothing to do with that kind of thing, then you've got a problem and a dermatologist might be better. So it depends on the confidence of the physician and whether you can persuade them to actually talk to the patient, send something to a lab, discuss it, and inform him or herself about the condition so that they know what to do.
Thank you. This question is for Dr. Lepping. Did you say that Primoxide is an anti-emetic? I may have misunderstood.
Do you mean Pimozide? Sorry, did I say anti-emetic? I meant antihistamine. But there's a couple of things I think that I wanted to say about Dr. Ku's presentation whilst we're on medication. There's a number of things that he suggested that I think in Europe we would consider slightly eccentric. So I just wanted to comment on that. Firstly, the use of alprazolam. We would probably try and avoid benzodiazepines because of their addiction potential. Secondly, the use of paroxetine that he recommended. If we choose an SSRI, paroxetine is probably the last choice we would choose because of its short half-life. And with a short half-life comes a big problem with discontinuation syndrome. So people on paroxetine are the most likely to develop serious problems when they try to come off high doses. And there are other SSRIs that where that is much less of an issue. Certainly buspirone is another one of these anti-anxiety drugs that is only really popular in the US and that we don't really use at all because of their addiction potential. And then I think you talked about doxepine, which again is definitely on the eccentric part from a European point of view. Equally, when he talked about the estrogen hypothesis, I've never heard of that before. I've never heard anyone who mentioned that before. So I think you should make your own mind up about that. And he talked about, I think, a monosymptomatic hypochondriacal psychosis. Now, that is actually similar to the old DSM classification of delusion and infestation. But again, he said that was used in Europe. I've never heard that used at all. I've only ever heard that in a sort of DSM-like context. That's just a few comments that I wanted to make. And obviously, I already told you that Pimozide is what Dr. Ku likes, and I respect that. It's there's nothing really that I can say absolutely against it. It's just that I want to inform you that it wouldn't be everybody's choice.
Thank you. So what do you do when you refer the person to your PCP and when it was mentioned to see someone in mental health, they quote unquote fired the PCP?
Well, it sounds like there wasn't a relationship established. And the person who's got the issues probably was felt somewhat insulted, and so they're going to react to that. Pest management professionals need to be very tactful. And I think the most important thing is when you're working with somebody, particularly if they're new to your account, is to become an ally with them, work with them, join with the client and say, yeah, you have something that's real. I understand it. I don't see what it is right now, but I'm willing to work with you. If you do a reference to a psychiatric entity immediately, you're not going to get a happy result. So it's all about time, patience, and empathy. And I could see that it would have caused a serious reaction by the client.
Thank you. The next question is, in response to submissions of any kind, we always write up a letter explaining our findings. Would it be good to suggest they provide this letter to their healthcare provider in cases of suspect delusional infestation? I guess my thought is that it helps explain to a physician what might be going on.
What are you talking about now exactly when you talk about findings? Are you talking about lab result?
I think what she's asking is she receives samples from the general public and they might not be finding anything, and they write a letter with that explanation. So she's asking, should she provide a copy of this letter for the healthcare provider in cases that's suspect of delusional infestation are indeed there?
That is a very difficult question because you can, sort of step over your discipline line.
No, I don't. This is Morgan. I typed the question. I'm from New
Okay.
Hampshire. And
Right.
we do identifications all of the time, and we always write up what we find. And I
Yeah.
just think, I don't know if writing there, when we get these cases, we usually write there was no arthropod material present in your samples.
Yeah.
And if there is, sometimes I've gotten like a leg of an insect before and I've written that, but there's nothing that would cause anything. I just want to know, I guess, if suggesting they then provide that letter to their PCP would be helpful. No, I don't want to diagnose anything by any means. I just want maybe to give the PCP something that says, okay, an expert has looked at this and they didn't find anything.
I can see exactly where you're coming from. I think the difficulty is that if you actually want to help someone, you will have to engage with their samples in some way. I can see why prophylactically you may want to do that, but equally it doesn't actually mean someone definitely has delusional infestation, and they also might pick something up that is completely different if they see someone else 2 or 3 months later. It's a very, very good question, I think, and a very difficult one to answer. But I would personally always encourage my patients to provide samples, because that is often the way into a discussion. So if you've already said they were negative, what you work with when you pick that up is what I'm trying to say.
And so in continuation, it would be, if this is just the first time encounter, I would suggest, reaching out and telling the client or the PCP, whoever you're working with, to get the client or patient to do their own sampling under specific instructions, such as using sellotape or scotch tape on a site that seems to be pinching. You avoid the word biting because that's inflammatory. We don't know, the jury is out. And then again, as I said in my talk, using a coffee filter over the end of a hose of a vacuum cleaner for samples. So you get cleaner samples. You then, at this point, are starting to focus the patient or client on a task. So they become part of the detective team. And you're going to get, as I said before, cleaner samples. And also it indicates that you're paying attention to them and you care. And that's, again, building the trust that you need when you're working with people like this. Does that help, Morgan?
Yes, thank you.
This next question is from Wendy Martell. She's coming from the regulatory community and she gets involved with pest management issues. I completely understand our conversations today. However, as a regulatory, what advice may I offer PCOs for communicating to their clients?
Can I ask what PCOs are?
That's a pest control operator.
Okay.
If a pest manager or pest control operator is suspicious they're working with a DI case, they should always work as two. They should always work as teams. When they go into a space, you need to have two people present. Again, it's conveying sincerity and interest in the case. And then again, careful sampling, but absolutely do not placate the patient's desires. You know, don't do any false treatments because you're becoming involved in their own cycle of thinking and you can get it trapped into this. So
you may also want to develop a standard response, like almost like a pathway, where if you have a suspicion that this is the case, you could say to the client that you haven't been able to identify anything suspicious. However, if they feel that they have an issue, maybe they want to see a physician about it. So in that sense, you're not making a medical diagnosis, but you're not minimizing the symptoms either that the patient or the client complains about. All you're saying is, from my expertise, there's nothing I can see or find here to treat, but I appreciate that you've got symptoms, but maybe you want to ask a physician to have a look at this rather than a pest control officer.